All right, good afternoon, everyone. Welcome to Ethics for Lunch. Today is small but mighty proud. My name is Mark Hughes. I co-chair the Hospital Ethics Committee, and Ethics for Lunch is an opportunity for both the Hospital Ethics Committee and the Berman Institute of Bioethics to engage with the community, the hospital community, about issues pertaining to clinical ethics. So let me just walk you through some of the CME information first. So to know that this is an accredited activity and that 1.25 hours are available, we go to 115. We have asked our panelists and myself to disclose and know that we have regulations with the CME office. We're not going to present any off-label use of medications. We have said this is open to everybody, both those that work in the hospital as well as members of the community. And our general objectives for the activity are to think about medical education broadly, but in particular with regard to ethics issues, thinking about safety and quality of patient care, translate things that we might learn from the literature into our practice, foster better communication among stakeholders, and think about ways to help take care of patients. Today, nobody had any commercial relationships with any entities. And the main objectives for today's session, which is going to be a review of the past year for Ethics for Lunch, is some of the themes that came up this year are sort of identifying who the legally authorized decision maker is, especially for patients that lack decision-making capacity. When either patients or families need to make difficult decisions, how do we help them do that? And then we're going to ask you all, what are the ethical issues of interest to you? And hopefully that will be a springboard for lunch in the next academic year. All of the cases that we present are fictitious. They may be based on something of reality, but they are made-up cases. If there's any chance that we will talk about actual patients, then everyone participating today takes this confidentiality pledge to protect the privacy of those individuals. If you want CME credit, this is the number 844-980-1555, and today's code is 51360. So that's what you can send as a credit message. And not to with CME office. And if you need more information, that's all available through the website at CME. Okay, so what we're going to do is look back as well as look forward for Ethics for Lunch. And I'm going to have the panelists introduce themselves. So Shannon, you get to go first. Who are and what do you do?
Hi, my name is Shannon Barnett. I'm the major, but majority of my time actually consulting with all of our state departments, which is serving through foster care.
My name is Laura Branger. I'm one of the infectious allergy medicine physicians here, and I'm also a member of the ethics committee. I'm Caitlin McGann. I'm a nurse on the allergy medicine team. CC site nursing and
Okay, so they are going to be reacting to some of the cases, but also any comments or questions that you might have about the topics that we covered. I've already told you what our objectives today are, and as I said, really want to try to also anticipate next year and find out what we should be discussing in the future for lunch. These were the 7 of the topics that we covered in the past year, the 7 lunch sessions. So we're going to try to cover some of those, and we'll have illustrative cases to go through those particular topic areas. One thing we're going to try to utilize today is Poll Everywhere. So you can either scan this or go to this website, and then I'll also give you the text message on the next slide. Thinking people are probably familiar with Poll Everywhere nowadays, but this should open up the activity for you. You might even have the first question loaded once, because I've already activated it. Everyone good with looking at that? Still looking? Oh, sorry, give you back. Good. Okay, again, I think it was familiar with, but if you need the instructions, this is how it's going to work. So you use your cell phone or you have a laptop or whatever device to get to this. The other way is to 22333. If you type in JHH Ethics 553, that will also activate the activity. And I demonstrate that for you here. And then you can start texting your responses. Okay, so that's just further explanation of doing that. And we're going to do icebreaker activities to start, and some of you are already started. We have about a third of you have gone to 2 of at least our 7 sessions this year, and third, or just about more than 4. So welcome to the regulars. And then here's the next question for you. It might be hard to read, but can you identify your role? Are you a nurse, physician, a nurse practitioner, physician assistant, social worker, chaplain, physical therapist, occupational therapist, medical assistant, bioethicist, broadly defined, researcher, community member, student, or other? Some people have multiple roles, but you choose what you want to categorize. All right, so we've got 36% are physicians, 18% for purple is researcher, 18% is social worker, 9% for students, and I think that's chaplain. Just interesting, just to know who comes to our ethics lunch. And then sometimes in ethics, we like to know about people's emotional state. So how are you feeling today? How it works, okay.
Oh, I'm forward to doing something more. Yeah.
Lunch makes you in the green zone, okay? You're angry, you might be in the red zone. Okay, well, a couple of you are in the middle, but at least some of you are in the green zone. Good to hear. Sometimes we're dealing with moral distress on our ethics consult, so all right. Now, this is a type-in. We'll see if this works. What topics interest you if you're thinking about next academic year? You can try to type this in and see if I did the bulletin board correctly. This might take a few minutes to type. Okay, justice, broadly defined, okay. Mental health ethics. So when there's conflict in goals of care, integrating religion, spirituality, and clinical care. So we typically have at least one of our sessions is with our spiritual care department. So we try to have a topic that relates to that. Addressing physician and caregiver biases, miracles is another spiritual topic. Ethical issues related to making care, cultural sensitivity and ethics. Islamic bioethics. Good percentage of people have interest in spirituality as it pertains to ethical issues. Okay, with dementia and personhood. All right, so I'll ask you at the end as well, but you can keep typing. We'll keep track of these for next year, and speak to our ethics committee at the beginning for September and beyond. Okay, so we're gonna move on to, the first, Ethics for Lunch, session was the challenges of caring for youth boarding in the hospital. So I'll present the case and then I'm gonna ask you, and it's a multiple choice, and obviously ethics can't boil down to multiple choice options, but, of the choices that I present to you, you have to choose one, even though you might think there's a better answer. And if you do think there's a better answer, then raise your hand and we'll bring the microphone to you and you can give your suggestions about how you might handle this. All right, so Ben is a 12-year-old with disruptive mood dysregulation disorder, attention deficit hyperactivity disorder, and oppositional funding disorder, who was admitted to the child psychiatry unit after getting in a fight at school and then making suicidal threats in the presence of his school guidance counselor. His parents signed him into the hospital. He was brought to the emergency room. They thought that he needed admission, so his parents agreed to that. But his background is that he's actually been living in foster care for the previous 3 months because his parents were not able to manage his behavior. And since entering foster care, he has run away several times, in addition to having frequent explosive outbursts anytime he does not get his way. After 2 weeks in the psychiatry unit, Ben's mood has improved with the initiation of antidepressant. He's learned techniques for managing his anger. And when the team starts to discuss discharge, his foster parents indicate that they no longer wish to have him live in their home. The Department of Social Services is looking for placement, but have not yet been successful. And his DSS caseworker says she will not pick him up from the hospital until the placement has been secured. So in effect, he is in the hospital indefinitely until they find his placement. But as Ben stays in the hospital longer than he's clinically ready for discharge, they thought that he was stable enough to be discharged, but they're keeping him in the hospital because they don't have placement. The team notes that he has return of his angry outbursts. The treatment team points out that as long as he's in the hospital, Ben has very little access to friends and family. He's not able to attend school. And these restrictions are believed to be contributing to the worsening of his behavior. So here is a question for you. What options are available to the hospital in accomplishing a discharge plan? One, you could send the hospital legislative liaison to Annapolis to lobby legislators and the governor to fund housing solution. B, you can keep Ben in the hospital as long as it takes to find housing. C, allow Ben to have time off the unit with staff, acknowledging that there is a risk that he might run away from the hospital. And D, have the hospital pay for a hotel room for him to stay with a 24-hour remote monitor. So let's see if you can answer those A, B, C, or D. I guess they may not be mutually exclusive. You might choose more than one, but you're confined to only one answer. So people are saying B, but there are some A's and C's. Anybody in the audience want to talk about how you think about this case? Yes, we'll wait with the microphone. Well, we're recording, so yeah. No, you're good.
Hi, I'm Owen. I'm actually social worker on the pediatric side with North, which is research for pediatrics for peds, and I was on general research for researching for adolescents, and DSS orders was my life. So in this case, it was kind of tricky because we wanted to keep the patient at ease and at a level where we would not have to re-admit them to the psych unit. We also needed to abide by the DSS policy handbook that we created. So in this case, B and C were the main things that we went to. We did as a team have to have weekly meetings to see what type of privileges we wanted to give to the patient, so that they could, feel like even though they are restricted to something to the hospital, they still had a sense of freedom while being here. But also just to ensure that a safe plan of discharge, we did have to keep them until we solidified a good placement. And that even looked like having placement options on the table. Like for example, We had a patient's relative who was out of their life for 4 years coming to the picture, and automatically people were like, oh, we could just send them home with that. But from a social work standpoint, he's like, well, they have not been in the picture for 4 years. They don't know how this patient actually operates. They don't know maybe how to control their anger, or manage your anger. If there was an outburst, we have, they don't know the medication, they don't know the routine, so it's just not safe. So, though we want this patient out, would it be safe? No. So here we're gonna have to keep them in here until we actually find that housing. So B and C were the main thing, but we also did consider A because the instance orders in the hospital is like on a state level of needing attention. It's not just a hospital thing. It's like, okay, who else can we reach out to see what we can do? So this is kind of like the A, B, and C. The B wasn't an option, but that was more so from a DSS perspective, not a social worker. So the DSS wasn't paid for the hospital. The state had the United States could, but I don't see that as recourse for a patient either, especially on the pediatric side of things.
Okay, great, thank you. Any other comments? Wait for the mic.
I was just saying that to Stu that if this question was on our social report, we would have had because it says what options are available in accomplishing a discharge plan. So option one is a nice option to do, but it's not gonna help us with the discharge of this particular patient. You know, we can let them off the unit, it's still not gonna help be discharged unless he runs away. So really, and C is not an option at all because it's not a legal or risk management perspective, so that's why I was saying B, because we have to keep them in the hospital as long as it takes to find housing, because that's our only option, and I think that's where a lot of staff feel very trapped. Because, yeah, we can do the other things, but in the end, it's not gonna accomplish discharge for this patient, and that's the question that everyone gets.
Let me challenge you on C. So let's say you do give him these privileges to have a little more freedom, decreases anger, and he actually does run away. Is the hospital under obligation to track him down and bring him back to us?
So that is a big topic of discussion right now, because we were putting hands on patients for a very long time. And then we found that DSS does not do so in the community, so that is a continuing evolving discussion. Where we are starting to not go hands-on and hold these patients down relatively new. That's those cases where we not held the patients down in the apartment or on the street, only to be told by DSS that they won't go hands-on when they come here, so it's very hard because we know that's not safe from what we've been taught all these years. But DSS is a different idea.
Okay. And react to the case from both the hospital and the DSS side.
Yeah, so I have a unique, job in that I see the hospital's point of view and I also see the DSS's point of view. One of the things I think about a lot is what's actually in the best interest of this youth. A lot of people don't want to be responsible for the youth when something bad happens, but sometimes I think we actually create more harm by trying to make sure the youth doesn't, a bad outcome doesn't happen on my watch. So this youth is probably better served if given more freedom, but that means that at least the hospital perceives more risk. I also think that there's this is like so many things have gone through here. We really need to build strong relationships because we actually improve behavior with relationships, and so many of these kids just don't have strong positive relationships. So that's one of the things I really work with TFS is that they have obligations, not just to find a student placement, but they also find adults to develop relationships with the youth, which does take time, but there's probably more term.
So if he's remaining in the hospital on this particular unit, and you're trying to develop relationships, Caitlin, could you speak to sort of nursing, if he's got angry outbursts and is lashing out at the nurses when they're trying to bring in medications or other things that, for his care needs. How would the nursing perspective go? I think it's.
Yeah, I think this is tricky. Being the nurse at the bedside for a patient like this, certainly a child. Especially when the child has parents who are not involved, foster parents who are now not involved at the bedside. He's kind of on his own, alone. And oftentimes I think that the nurses are there to kind of pick up the pieces and fill in the gaps. In addition, they're doing their 12-hour shift with all the tasks that they have to accomplish. So it's demanding, and we also acknowledge that with this young man, he's somewhat unpredictable, and there could be risk involved. And so it's weighing, how as a nurse do I kind of exercise that compassion in a way that reaches this 12-year-old boy who is, physiologically, chemically challenged, and also very much alone, in a meaningful way, and also maintain my own safety. I think sometimes the nursing on that unit oftentimes needs to kind of go together. Oftentimes it's helpful, I think, to rotate these patients. I know that would be maybe a little counterintuitive when we think about establishing relationships, but I think also being careful not to have one or two nurses who can only take care of this child, because that just increases the opportunity for, children are good at manipulating whether they have some sort of mental illness or not. And so we don't want to put our staff in a position to feel like they're one or two nurses that can shoulder the burden of taking care of this patient. So I think we need to kind of alleviate a single nurse by, kind of starting that out for the vision. And for the long haul, if the patients have been in the hospital for a while, and there is distress among the staff, I think, very reasonable to, there's certainly hospital resources, but I also think just as a team, maybe weekly check-ins, putting something in place where the team, the managers involved, the nurses can sit in front of people and say, what's going well, what's challenging, what's the flavor of the week with this young boy, what is going well and what do we need to work on. Those are some of the challenges, I think, in terms of, having the wherewithal to care over time for a boy in this situation.
I think a couple of things. I think there's one, how do we get this youth discharged? So I think we've started having more frequent meetings with DSS. What can the hospital do to facilitate maybe helping DSS write? There's a form called an 818 form that goes out to help. How do we help that narrative? Sometimes kids will actually do a all about me sheet that goes out to potential placement. So there are things that I think the hospital staff can do to try and make these happen. But then I think a separate issue, and I think we've gotten better in the last year as a hospital staff, is a separate issue is, yes, we have like a parallel, one track trying to get this youth discharged, but another track of how do we, while this youth is here, how do we make that the most positive experience for the youth? And I think we've done a lot more on how we have structure, who can that youth have a relationship with, how can they have contact with family, how can they get an education, how can they leave their room. So I think separating that, how do we get the youth out of the hospital and how do we make the youth have the best day possible? Again, I think we've separated those two. I think that's been helpful for the youth who are in the hospital. And then I think the third thing is continuing to advocate both on a state and national level. But this is a problem I was with the pediatrics, the pediatric, kind of pull out of the bioethics conference, and this was the topic that all of pediatrics was the most interested, like that's what we talked about the whole time. So this is not a Hopkins issue or Maryland issue, this is a white issue. So I don't know if we'll have great solutions, but I also kind of get the sense that Hopkins is actually has some really is making more progress. Other places that I know.
I don't actually know the answer for this, but just curious with, having, post-pandemic, are these students able to do some virtual school with their county schools? Have we had patients that have engaged in classwork in virtual settings? I know their virtual options still exist for most county schools. I just was curious.
I think more often they're getting like, because they're just here temporarily, they're getting more tutoring.
Okay.
But that.
Who provides the tutor? Is that DSS or is that hospital?
Or the education.
That school system, like,
Mm-hmm.
and are there other limitations on the child psychiatry unit of what, a youth can do or not do? Can they have a cell phone? Can they have friends visit? You're talking about giving them some freedom. Are there limits to what can be offered?
There are limits on the inpatient unit, for the house of the consultation. But they are trying to look at ways to increase contact on their phone. Call out, and so just trying to figure out. If there's advantages to being on the child, like, because you're uneven with other kids, and there's more activities to do versus on a feed floor, but there also are child restrictions, for the child that, there are certain things that you can't have for safety that you have on the extra course, there's probably both pros and cons for either being on a site unit or, being on their own.
And might that be an option that, the patient that's considered stable for discharge might be discharged to a pediatric ward and not kept on the psychiatry?
As far as I know, we have not ever done that. It's someone from before, unless somebody knows, I've never heard of us discharging to the general piece before. I mean, I've seen these banned. But yeah, before.
We've done it the other way around.
Yeah, if you meet criteria for.
Any other comments or reactions from the audience? Yes.
I don't know what this says now, I don't know what this says to me. Because I feel like there are many more who are operating the same thing. And in my opinion, this is not going to be an ridiculous and many more going to be. I think it is time that we go to the government and just kind of like shine a light on the issues that are happening around. All these other items are okay. But it's not going to come because it's going to happen again, it's going to happen again. And so we can try to get to for this to that's not solving the entire problem.
So we need system change, even though for this particular individual, there needs to be a solution, and it might be that it stays in the hospital until there's placement, but we need to advocate for, broader, some recognition that this needs to be taken care of throughout the health system, not just in Maryland, but it sounds like we should. All right, well, we'll move on. So the second topic that we covered, is medically effective, especially at the end of life, ongoing enduring ethical challenge. Here's the case for you all. So Ms. L is a 92-year-old with vascular dementia and metastatic pancreatic cancer who was admitted to the oncology service for failure to thrive. She had nausea and vomiting, and had a fall at home, which was what precipitated her admission. She was found to be dehydrated, had acute chronic renal insufficiency. She was stabilized, she was given IV fluids that helped with the dehydration and her renal failure. Palliative medicine consultants came and helped the oncology team in managing the nausea. but she was still having a poor appetite, would not eat even if she was offered spoon feeding. Her son has been living with her and has been her caregiver as her dementia has progressed. She is deemed not to have decision-making capacity on the basis of her dementia, and her son is her surrogate decision maker. There are no other children or other family that could serve that role. And she's never completed an advanced directive. So they're talking with the son about plans. Son has placement of a percutaneous endoscopic gastrostomy tube to provide her enteral nutrition. His rationale is that she always described how terrible it was to be hungry as a child during World War II and after the war, growing up in Eastern Europe. He wants to extend her life as long as possible and really feels that we have to give her nutrition. I don't want her dying of starvation, is how he views things. At the same time, though, he recognizes that she's got advanced cancer, that her dementia has been progressing, that she is nearing the end of her life. And he requests that her code status be changed or be made no CPR with the option of providing intubation and mechanical ventilation if she had respiratory distress. So that's the situation. And here are the questions for you. What should the oncology team do? A, honor both the son's requests by placing the G-tube and making her do not attempt resuscitation or no CPR. Honor the son's request for do not attempt resuscitation, but not the G-tube. C, tell the son that he cannot make a decision to do not attempt resuscitation as a surrogate decision maker. And D, tell the son that the G-tube and CPR will not be offered because they are medically ineffective. So here is your chance to answer. Again, there might be other choices that you would think of, but we'll keep it to these four. I don't have a tally of how many people are responding, but thus far, everybody is saying A. All right, anybody from the audience want to give a rationale for why you chose A? All right, well, we'll go to Dr. Berninger. Oh, there's a D. Nursing late vote for this might be medically ineffective. So, any initial reactions to this case?
You have a few more questions about the case. This is obviously something that we encounter very frequently in the art as I see it with my colleagues in the back there. So we have a patient who has no advanced directives, we have no healthcare agent. Surrogate decision. My first question, looking at the case, is this condition and stage terminal? Absolutely, step against stage condition. The fact that she has minimal oral intake at this point has multiple comorbidities in addition to her chronic cancer and her dementia. I like looking at a terminal condition as well. In the state of Maryland, terminal condition, imminent death is left up to physicians to decide what that means. So we're doing a little bit of vagueness there. So some physicians may not say that this is necessarily terminal based on their what imminent means to them, but I would definitely say it's end stage condition. And I would also say, in my opinion, this is terminal. So we have a surrogate decision maker. In this case, the son, right? We have no other next of kin. So he is the legal decision maker. And if he wants to make decisions about unsustaining treatments, making her DNR, he is able to do that. As long as two physicians certify that this patient has an end stage terminal condition. So yes, it is appropriate, this patient is DNR. I also think in thinking about medically ineffective treatments, I think this brings up a lot of moral distress among physicians, nurses, other staff members, right? What constitutes medically ineffective and medically not beneficial?
So I think CPR in this case would certainly be medically ineffective. We know at the end of the day that this patient is not dying from starvation, this patient is dying from. And it's really important to kind of normalize this for patients and their families at the end of life, that as patients progress towards the end of life, that it is normal, common, and expected that we stop eating the drink. Patients don't necessarily, feel hungry and thirsty the way we did previously. And it's really important to normalize that, that they're not sensing that they're starving. I think these cases tend to be very emotionally challenging, because, a lot of our culture centers around food and drink and sitting around the dinner table. That's the idea of not feeding your family member can be extremely emotionally distressing to someone's loved one. But I think we also want to talk about the harms of putting a feeding tube in someone who has dementia, putting a feeding tube in someone that has cancer, because we know that it doesn't improve outcomes, it doesn't improve quality of life, and there are harms associated with it. So many would argue that that would be medically effective. So I think this case really brings up the need for more conversation with the son, before we make decisions. I would consider that, there could be more talk about whether putting a big into this in addition to the supplement would be medically effective in setting the stage of trauma. And I do sense on it. Yeah.
One of the things I was thinking about this is we tell surrogate decision makers, you're supposed to be making decisions based on what you think your loved one would have wanted. And he is saying, my mom has said, they don't want to feel that sensation of starvation. So I think that kind of getting, that complicates this. I think not in our minds, because again, healthcare professionals, we don't believe that she's feeling the starvation. I believe that she's feeling that, but I do think that just, at least you have to have that conversation and know that we always tell surrogates, do what you think based on previous conversations with your loved one would choose. But I know I had a conversation with my mother 9 years ago where she said, I would not. She's like, I would not want to starve to death. I tried to give her something with, but I think it's very interesting. He's trying to make a decision. He's trying to do what we asked him to do, which is do what he thinks his mother would have wanted based on previous conversations. So helping him learn that he can still be, he could not choose the pay and he would still be going on her wishes. I think helping him through that is probably kind of challenging.
My response was more to the audience's selection. I was really surprised that everybody, for the most part, chose the first response, because that would have been my choice. And I think cases like this really highlight sort of the challenges that we come up against now that we sort of swung the pendulum from, paternalistic forms of medical management, decision making, kind of all the way over to sort of this patient, family centered, driven model. And I think we see all the time, these sort of a la carte, care choices in terms of, well, you can push drugs, but we don't want the CPR. And you can resuscitate, but we don't want the breathing tube, or we're not gonna resuscitate, but we want the breathing tube. But I think it's hard, because essentially we've done a very, very good job of putting patients and families kind of to the center of everything, which I think is wonderful in many respects. But I think ultimately, they're not medical professionals. Well, typically there is always one family. But for the most part, we still have to, that doesn't mean that we surrender our role as sort of the experts in these given scenarios. And so for me personally, I would have chosen to be. But I have in my notes that this would require, as, Lauren suggested, this requires a really thorough explanation. Because essentially, the fact that he's voicing his mom's wishes, it's wonderful, right? He's sort of meeting us where we would want him to be. It's, he's representing his mom's voice is center of the conversation, even though she's not able to participate. So he's doing everything that we would want a surrogate to do. But at the same time, there's a lack of understanding there, and there's room for conversation and education, and maybe some reframing. So, that's a lot of what we do on the palliative team is we want to get to know people, for who they are beyond their disease process. What do they value? What are their goals? And in listening to those things, we need to be able to ask ourselves, are these goals realistic? Are they achievable? Are we setting ourselves and our patients up for failure? In this case, I would say this necessitates, much more information sharing, education, listening to the family. What are some other ways that, you love your mom and care for your mom, and that, what always made your mom feel nurtured and taken care of? And there's other ways other than food, of course, is essential, but there's other ways that maybe we could offer the son to help him feel as though he's taking care of his mom and loving her in different ways, as she goes through this natural life process. So yeah, I think it just shed a lot of light on this sort of distinction between this sort of paternalistic and patient driven decision making, surrogate decision making. And I think just the need to find that happy medium. And I think oftentimes the onus is on the care teams really to be firm in their expertise and their ability to guide patients and families where maybe there may be a knowledge deficit or an understanding.
Reactions from the audience? Anybody want?
I don't know what you're saying. I chose number one, because this patient is gonna die. Then his mom has to continue living. And I think what he's doing is to allow himself to look at himself in the mirror. Tell the mother that I'm speaking from a doctor's point of view. This, what we're doing number one, is not gonna change much. But it's gonna give the son the satisfaction that I think all that puts in alone. It's not like he doesn't know that the mom is dying, but he's grappling right now. And anything that he can do, and the one thing that he feels like he can control is food. It's like he don't give us, it's like this can. So that's what is still in his power, the other things are not. And so he's working on that, that's why I put number one. To give the son that control that he needs to know that he needs to get.
And just to respond, and I love the problem. I think there's definitely a time and a place to consider what would occur, right? If we have recommendations or requests from patients and families for different care elements or different interventions, I think we should ask ourselves is what's the worst that can happen? What's the benefit? What's the harm? What would it hurt? For a peg tube in a little lady like this, I think this carries a higher risk, and it certainly is a more invasive procedure. Whereas if we want to put a little oxygen via-nasal cannula on somebody because that makes their family feel soothed, that they're seeing some airflow and things like that. I do think there's a time and place for it, but in considering, I think there's moments where we're going to be able to, as a care team, say, yes, you know what, this is going to be more for the son. It's not going to harm his mother, and it's okay. It's just okay to say yes in this circumstance, or to make an exception, however you want to look at it. And then over here, you know what, this is really invasive. The people who are doing these procedures are now taking on undue risk for themselves and putting patients potentially at harm. And there really wouldn't be a benefit. And so we're gonna kind of toe the line and say no. That would be my response to
I work in the pediatric ICU, as a social worker, and I've been up there about 10 years, and over time, my opinion has changed. And I voted for D, because I think one of our responsibilities here is to be the professionals and you have honest conversations with parents. And I don't think we do that very well many times. When we behind closed doors and talk to each other and say, this child's never going to survive. We have no way to make this child better. But we will continue for weeks to months to push treatment because the parents want it. And we just don't feel comfortable setting limits on a parent because the pendulum has swung so far to parents and family involved care. So I have certainly over 10 years come to a more, we have responsibility to patients to do what is, if they're medically ineffective treatment, not just to do it to make people feel better, to make families feel better. And it's tough, there's a really hard conversation. Probably the hardest conversation we ever have up there. And I think sometimes it's like it's a hard week.
Hi, my name is Mariah Barrett, I'm a health assistant. I'm listening to this conversation, just going to be kind of a lay person, potential family member. I wanted to ask more about, in this case, what would the harm be? Because it seems it's really important to understand that. It's important for their son to understand that, especially. And I wonder about the kinds of cases that our colleague was talking about in pediatrics. Is it more that people are able to listen and understand what the harm would be of continuing treatment, but they somehow don't trust the healthcare professions for other reasons, or is it that they don't understand the harm, or is it you can't even have that conversation? I mean, in this main case, what are the options for really having just really connecting with the son to help him understand what the harm is?
Thanks so much for that. So absolutely, I would say that there are harms associated with putting, placing this patient on artificial nutrition, setting up for advanced malignancy and advanced dementia. So number one, I would be worried in this patient who had a lot of nausea and vomiting, that kind of, providing artificial nutrition, would probably worsen that and instigate the nausea, once again, and probably lead to more discomfort. Number two, I worry in a patient who will eventually become likely more confused from, the cancer and already has underlying dementia. There's a risk of that too becoming dislodged, which obviously causes discomfort to the patient. Also leads to a lot of hospitalization. We see a lot of patients coming in from skilled nursing facilities because their tubes dislodged because they were confused and they didn't know what they were doing in the hospital. Sometimes we find that leads to patients being in restraints because they're pulling out the tubes, and that's uncomfortable. As we get towards the end of life, we're providing all this extra hydration through these tube feedings, and these two patients often become volume overloaded, which can lead to swelling, can lead to worsening respiratory distress at the end of life. And additionally, if someone is tethered to a tube, it makes them less mobile, and so it leads to skin breakdown. See, these are a lot of the harms we need to address with family members who are requesting these treatments that we don't recommend.
Gonna respond to your how do families see it? I think we have just a lot of data on just how human brains work. And we know people minimize harm and maximize potential benefit. So just that's how our brains work. Which makes I think these conversations really hard for members. And I think it even is when the family members and a healthcare worker, we still see healthcare workers who would probably be on the opposite side when it's their patient than when it's their family member. It's so much easier to hang on to potential benefit and minimize risk, and that's how our brains work. So I also think we need to validate that it's not that families are being difficult or that they are cognitively not intelligent enough to grasp this. This is just how our brains are designed.
Yeah, and to build on that, I was actually gonna say, I think a lot of times we see families, it's not a lack of understanding whatsoever. But they'll listen to the laundry list of risks and then they'll say, okay, we'd like to do it anyway. Because ultimately, the alternative is death. Those risks, okay, we'll take, like, you know, if the percent is 0.0001, then something's gonna go well, we're gonna put all of our eggs in that basket. And that's why we have, you know, conversations about miracles and, you know, I think the whole spiritual, religious, cultural pieces start to come into play very strongly also. But yeah, I think it's great what Shannon just offered, because I think that speaks to families just really being willing to say, okay, we'll roll the dice.
Sometimes I think we really need to shift our focus away from talking about what we can't do and talking more about framing it as what we can do for this patient. And so oftentimes, by the time I've seen a patient that been told 50,000 times everything that can't be offered or won't be offered, right? And there's, you know, understandably, there's a lot of mistrust among the patient population, and just kind of reiterating that over and over and over again, you know, sometimes really doesn't help us go forward. So focusing on the things that we can do in this situation. So for example, proposing an alternative perhaps to this feeding tube that the son is requesting. You know, I'm really worried that this would make your mom more uncomfortable. I wonder if we could carefully hand feed her, do something called pleasure feeding, so that if she wants to take food and drink, we can still allow her that, right? And then she can always decline it. I wonder if that would be a better option in this situation. So kind of focusing on the things that we can still do, as opposed to things that we absolutely no will not be beneficial.
Wanted to address C, nobody chose it, but there is a little interesting nuance in Maryland law where what can a surrogate, you know, not a healthcare agent that's been named in advance directive, but a surrogate that's based on that legal hierarchy that I showed you, what they can and cannot do in terms of end of life decision making of withholding and withdrawing life-sustaining treatment. So there's this algorithm which you cannot see because it's too small, where it's you have a surrogate that's available, but the patient doesn't have an advanced directive, has made previous decisions. If you follow down the left-hand side, you're not going to be able to read. I can't read it even with my glasses on. But one of the things that Lauren mentioned was a surrogate can only make decisions to withhold or withdraw life-sustaining treatment if two physicians, the attending physician and a second licensed physician, have determined that the patient has a qualifying condition. Those three things that we showed: the terminal illness, the end-stage conditioning, or persistent vegetative state. So Maryland says a surrogate can only make decisions with withholding and withdrawing if the patient has one of those three conditions, and that's been documented by two physicians. The interesting little nuance is, so that's that middle box on the left-hand side. If you come down, let's say the person doesn't have an end-stage condition or terminal illness. We've determined this woman, you know, with her both on the basis of her progressing dementia, has an end-stage condition, but also with the metastatic pancreatic cancer, certainly has end-stage, but may also have terminal illness. Let's say you don't have either of those two. The thing that the Attorney General in Maryland has said is the surrogate, you could still go along with the surrogate decision to withhold or withdraw if it does not breach standard of care. So if other similarly situated patients and clinicians would arrive at the same decision that this is an appropriate decision to withhold or withdraw, then you can agree with the surrogate for their decision. So this, in particular, the no CPR, that's withholding a life-sustaining treatment, the surrogate can make that decision because it's not a breach of the standard of care. The other thing that people mentioned was whether this might, either the CPR itself or the artificial nutrition might be the definition of medically ineffective treatment, as much of our discussion has been. So this is the definition for Maryland about what that is. To a reasonable degree of medical certainty, medical procedure will not prevent or reduce the deterioration in the health of the individual or prevent the impending death of the individual. An impending death is also a vague term that is left to the discretion of the clinicians to decide what impending means. And the Healthcare Decisions Act in Maryland would say a physician is not legally obligated to provide medically effective treatment. So that would be another part of this conversation with the son for both of these things, the CPR, which is already saying no CPR, but also the artificial nutrition. Does it meet this definition? For our hospital policy, again, something you cannot read, which I'm not going to bother to go through, but we have a hospital policy on medically ineffective treatment and a fair process for approaching that when families disagree with our clinician's assessment of something being medically effective. So being able to hear them out, whether it's the patient or their legally authorized decision maker, opportunity to meet with the ethics committee to explain their rationale for why they want that treatment and moving down the pathway. I'll just refer you to the policy rather than going through each boxes, but there are, again, in accordance with the law, ways that you could have two positions say something's medically effective and will not be offered. Okay, but ethics consultation there on the left is part of that. Any comments or reactions to that? And then I'll just say that, for CPR itself, so the Healthcare Decisions Act also says, if you anticipate that a patient might experience a cardiac arrest, cardiopulmonary arrest, that it is an opportunity to try to discuss with them before that event happens. So either with the patient themselves or their authorized decision maker. So it is also our responsibility to have these conversations with the decision maker before that emergency treatment happens. And the Attorney General also said, CPR could be considered medically effective, either because they've already got a fatal illness or after they had the resuscitation and it was successful, but they would then be actively dying. And that's an opinion letter from 1999. So you don't need to offer CPR if you think that it is medically effective. All right, so that is that case. Any other comments or reactions? All right, we shall move on to thinking about neurologic end-of-life care. So challenges there. So this is Mr. S, a 72-year-old with a history of coronary artery disease, hypertension, atrial fibrillation on chronic anticoagulation. He collapsed at home and is brought to the emergency department by EMTs. Head CT scan shows a massive intracerebral hemorrhage with blood in the ventricles, compression of the ventricles, and a midline shift of his brain. It's a pretty dire situation. He is stabilized in the neurointensive care unit, but at 48 hours, he remains comatose. And at that point, he loses brainstem reflexes. Repeat imaging shows that the brain is now herniated onto the brainstem. The neurointensivist approaches his wife and children about the need to perform brain death testing. A first exam is performed and is consistent with death by neurological criteria. So the team have to wait a period of time. The team plans to do a second exam the next morning, but when they approach the family, this time the family objects and says, no, we do not want that second brain death exam. If that were performed, then the patient would be declared dead. And so, no, we want to give the patient more time, see if he will wake up. We just don't believe that this is the end, given more time. So here are your options as the audience. What should the NCCU team do? A, abide by the family decision and plan for placing a gastrostomy tube and tracheostomy. The patient won't be able to breathe on his own, so he'll need the mechanical ventilation. He won't be able to get nutrition other than through enteral nutrition. Go ahead and perform the second test without family permission. C, request the chaplain meet with the family. D, perform ancillary testing such as cerebral angiography and EEG to then convince the family if those tests really don't show any brain activity or brain circulation, then tell them that really requires us to do the second exam. So of those four options, what do you? We had 12% chaplains in the audience, so maybe that's why they're choosing the same, but they shouldn't do that. But everyone's going with that. Anyone have any more opportunity to answer? All right, so we've got the B and C, but people are going to C. So audience reaction, anybody want to give their rationale? We're getting a few more answers here. All right, anybody on our panel want to respond to this?
So unfortunately, this isn't something that we uncommonly see here in Baltimore. Patients who progress to death by neurologic criteria. And a lot of times these are very emotionally distressing cases. They're often either getting acute hemorrhage, like in this case, where it's something related to a trauma. So a trauma, either a motor vehicle accident or the gun violence that we see here in Baltimore. So sometimes people are just trying to grapple with what exactly just happened, and we're talking about, testing their loved one or death by neurologic criteria. So I think it's really important from the very beginning to be very clear in communicating with these family members that this is what we're worried about, and these are the steps taken moving forward to confirm what we're worried about. There's a lot of debate in the community about this, and the American Academy of Neurology actually recommends that you don't need to obtain permission for death by neurologic criteria testing. It should be equivalent to testing for circulatory death, like this heart stops, right? And so, they would argue that it should be the same process. We don't ask permission to declare someone dead after, for example, a heart attack. Why should we need to go through additional steps to gain permission to declare someone dead by neurologic criteria? But again, these cases do come up a lot because of the distress of the situation. Families, wanting to hold off on really learning what's going on. Many people already understand what is happening, and they just don't want it to be real. Is what I find. So absolutely, I would say B and C. B and C are correct, but I would certainly, we would be very much involved all of our support, social work, chaplaincy, nursing, palliative, as much support as we can get for these situations. If you want to talk to the nursing perspective.
I just know that, we've done with an institution, we've done because, we felt like we needed to add additional data points for families to really kind of absorb and understand that their loved one's rights was no longer received. Well, I think to Lauren's point, I imagine it would be easier given time on the front end. We anticipate as a 13 of this patient is like brain dead, the brain death testing. I would kind of front load and give a little bit of time in the beginning, because once that gets started, we know that, the second test has to happen. So many hours of the first test, and we also know that if the second test is positive, that, that patient is considered dead at that moment and pronounced. And that, I've been parts of, situations where the family didn't fully grasp that that was going to occur after the second test. And it was just a total shock to their system that suddenly, that was it. And they were, imminently waiting for tea to come in, breathing too loud, et cetera, et cetera. So I think
everything we can do to kind of anticipate and help the family anticipate, and again, it's this question of, does it hurt to give the family 6 additional hours on the front end, to meet with the chaplain, to talk with their family who lives in California, to have somebody be able to catch a flight, whereas we understand that it becomes much, much more difficult to keep these patients kind of ventilated and going on, after. So, nursing, gosh, the challenges are just kind of similar to all these other really emotionally charged experiences. You know, these patients are critical, and they're fascinating, for lack of a better word, and a lot of times, you know, thinking about organ donation for this population. And so, you know, the nursing aspect is, it's kind of awesome what we do to be able to have, you know, these organs go on and create life somewhere else. And so, you know, you're checking labs, and you're maintaining pH, and you're keeping a very, you know, running a very tight ship for a period of time, while all of these conversations and really heavy things are happening in the background. And you're also keeping that and being in process for the family constantly, on what to expect and how things are going to unfold. So, I think, you know, these are the very cases that, probably make ICU nurses feel challenged and excited about what they do, but they also do heavy work. So I think just knowing where to seek support, again, rotating these patients, those types of things, but lots of opportunity to contribute to success. Going back to the chaplain answer, so I think we have a number of chaplains who are in the just here. There are certain religions who actually reject the notion of great death, and that can become a very complicated factor. For example, the Orthodox Jewish community often rejects the notion of great death. So, the chaplains
You will be able to think that when every time you present it to the community, they have to understand you. And the family takes out in the identity investigation, it is suicide. In that, they don't want to have because some person has been that. Those are the questions I get to deal with every day, because they're not sure if they're intervening in the will of God. This is right on because that they do, if they're still breathing, they need to be here. For example, I have things like that, I went on for so long, I thought it was someone between ready because the husband did not believe that the wife was dead, because I don't want to be sure the wife is still here. So yeah, there are some religions that believe that, so it just takes me having to use theology sometimes. Also, I'm very open to scripture in the room and explain where it's coming from and that. And sometimes in my spirit, and I've seen other places, I feel that's not really true. Maybe it's, what they're doing, that's what they're going to do. If they're dealing with the will of God, the information we're not going to do, if the answer is no, then it's not the will of God, and she is still. And that's always very hard to answer. So, to be honest, I don't always really get an answer.
I think it highlights just the challenges of the situation, and again, the idea of getting as much support for the family as possible, and the chaplain can be a resource for that. Okay, well, we've got 5 minutes, so we'll try to do at least one more case here. So this is informed consent, or in some respects, decision-making capacity. So this is the situation. So Mr. A is a 57-year-old male, travels to Johns Hopkins from his home in Africa to get a second opinion at the insistence of his family who live in the United States. He's been steadily losing weight. The workup reveals that he's had to date is sort of vague. We don't really know what happened back where he lives. He has limited English comprehension, so is not really able to provide much of the history. He does indicate through an interpreter that it's permissible to talk about his medical workup. with his son. His son was sort of the one that said, "Dad, come over here and see if Johns Hopkins can figure out what's going on." And for a period of time, the patient was staying with his son. The workup reveals that the patient has metastatic lung cancer. The clinical team feels that the patient is at the end stage of his disease and he will die soon. The patient's son indicates that the patient should not be told, because it's common in their culture to say the words cancer or death. The team wishes to recommend that the patient return to his home in Africa, where the rest of his family is, but this would require explaining his diagnosis and the need for some speediness to get it back on the flight back home. So that's the situation. What should the clinical team do? A, tell the patient his diagnosis. B, ask the patient his understanding of his work and diagnosis. C, tell the son to tell his father to return home. D, offer him chemotherapy, but tell him that it's vitamins to get him stronger. And you might have another option on your list. Okay, so most people are going with, try to talk to the patient. And I guess you can't use, you're going to abide by the son's wishes, can't use the words cancer or that he might be dying, but just ask him, what do you think is going on? Some general way of asking that. Anybody in the audience want to explain your rationale for the choice? Or why people chose A or C? Anybody on our panel want to respond? Oh, there we go.
So I think for me, it wasn't, I don't want only one or the other, but answering B is a prelude to moving into A. I work in pediatrics as well, and sort of talking about, similarly what Sue was saying, we don't do a very good job sometimes or often, talking to families and patients about their experience and their disease or illness process. But oftentimes they know. And they may not know the discrete, Latin words used by physicians, but they know that they're sick. They can pinpoint where things hurt or how they hurt and how things have changed over time. And it could very well be that though culturally, the son, believes that certain words shouldn't be used, that doesn't mean that his father doesn't know that he has cancer. And so if we offer the father the opportunity to share his experience and what he understands about what's going on, he may already be there. And if not, he may ask questions or set the groundwork for moving forward the conversation with the son, and essentially helping the patient to have the son allow him to know his own truth. That makes sense.
Do people think that the patient has a right to know that he's dying? And would you have this conversation with the patient with the son present or not present?
That's the patient if he wants to.
So always go back to the patient and ask permission. So you want to talk to him about what's been going on in the hospital. Do you want your son to be part of that conversation or not? Leave it to the discretion of the patient, and then do as Simone was suggesting, try to get into the conversation, see what he's thinking about. Alice?
I was gonna say, one thing we've done, I know with pediatric patients is ask the patient what they want to know. So, the son's, I wouldn't just take the son's word that he doesn't want to hear these words, but I mean, if ask the patient, how much would you want to know? What types of things do you want to know? Not want to know, hopefully with a very good, interpreter, any person.
I guess also part of that is, do you want to go home? How important important is it for you to eventually get back home? You come to the United States for this workup, do you want to continue it, or what are his goals? All right, didn't really cover decision-making capacity, but it is, one of the things, number 2 there is understanding of your condition. Either we're using a surrogate, if that's what the patient wants, or in this case, trying to ask the patient who's understanding the situation. We didn't get to the patient that might think about having research done on those that have been declared brain dead. So I won't go through that case, but I will leave this one to you. If you have earlier topics of interest, send us an email is another way to do that. mthughes@jhmi.edu. You can let me know, and we can think about that for next academic year. With that, we will thank you for coming today. Enjoy your summer.